Okay, so good morning, everybody. Welcome to the resuscitation track. The hall is full, so a lot of interest. And I first want to thank the organizing and scientific committee to having me here at the SASM conference. And it's an honor to introduce very important and very notable speakers. And the first speaker, I'm very honored to introduce one of the wonder women in emergency medicine is Dr. Aysha AlMemari. Dr. Aysha, I don't have to introduce her, but I'll give a short one. She was the head of the emergency department in Mafraq Hospital, but recently moved to the new big Sheikh Shakhbout medical city in Abu Dhabi. And she's also the program director of emergency medicine, and even recently she obtained her MBA last year. So please, Aysha, you will be talking about the paradigm in resuscitation and how to effectively save lives. Please.
Thank you. Assalamu alaikum. So my only disclosure is I do have many questions. I'm not sure I do have all the answers, and perhaps most of the answers I don't have them. But what I believe is my role today would be to make you think about resuscitation, how can we save life effectively and better than what we are doing, and then I'll leave you in your own to find the answers that I could not find. Now, the EM dream is what you saw a few seconds ago in that video. We all go into EM thinking our main role is to save life, is the resus room. I keep hearing it from my resident. They want more resus shift than regular ED shift. When the reality is, as you mature in the specialty, the challenge is not the resus room. Once you master your ABC and resuscitation, it becomes a piece of cake, but then the challenge is the crowded ED, the waiting room that's crowded with many patients that they don't look sick, but they could potentially be about to arrest. And then all the patient you may decide, should I send him home or should I keep him? So what we'll try to do is to explore what's the resus paradigm, and then opportunity to improve ED resuscitation, and as well discuss effective resuscitation outcome measures. Now, if you think about resuscitation, it's simply the action or process of reviving someone from the unconsciousness. So someone who is dead or about to die, and simply you try to prevent them from dying or to bring them back from death. And that's as simple as that. I remember when I started my residency, I was scared of cardiac arrest because for me, I could kill him. But then I realized he's dead already. If you bring him back, you have done something. If you don't, well, he was dead anyway, right? So to put it in that frame of mind, it makes you feel more confident, more comfortable resuscitating people. Now, what's a paradigm? Simply, it's a model. So if you think of resuscitation as a model, that would help you to zoom out and then look at all the angles that that constitute resuscitation larger than that moment in the resuscitation room. That moment in the resuscitation room is important. However, it's only one facet in the process. It's not the whole thing about it. So if you want to start from the community, OSHA, so out of hospital cardiac arrest. So that's where kind of things start. And I'm not talking about cardiac arrest outside hospital, but how can you prevent that cardiac arrest from happening to start with? So if you want to think about everything that happened before you come to the point of patient arresting in the community, then patients who walk into your ED, but they are in the pre-arrest phase, where they could arrest in the hospital, in the ED itself, or arrest after admission in the hospital in the first 72 hours. Then you have patients who arrest in the ED themselves, and then you have the phase where it's post-arrest. So they arrested, you have ROSC. So what's our role after ROSC? If you ignore one of these facets, then your resuscitation perhaps model is not complete. And your effectiveness to save life, you'll save some life, but perhaps you're going to miss a few of them. So if we start from the first facet, OSHA, what do we know? We know that bystander CPR does work. And we know as well that use of AED does save life. So having more AEDs around in the community does save life. Now, there has been many attempts in Middle East around to improve CPR training and as well to improve distribution of AEDs in the community. Then regarding the dispatch factor, so shorter call to arrival time would give you better as well sort of outcome. Then regarding patient factor, prevention and focusing in non-communicable disease would as well help you to prevent the cardiac arrest from happening. When you come to process factor, now the first reference there is a recent review article in Circulation that looks at all the intervention that you do to prevent cardiac arrest or to improve out-of-hospital cardiac arrest outcome. And I would encourage you to capture the screen and read that review article. Simply, many of the RCTs done to look at out-of-hospital cardiac arrest and how to improve outcome clinically. So, for example, ACLS ambulance, so the OBAL trial, giving epinephrine by EMS on the field, and many other interventions did not really deem being beneficial or improving outcome. Perhaps IV epinephrine in the pre-hospital might increase survival, however, did not increase recovery, neurological recovery. So you could prolong life somehow, but if the patient is not back to life or functional after that, not sure how effective that as outcome. Now a closer look to how are we performing in Middle East. In the bottom, Denmark, out-of-hospital cardiac arrest outcome, 16% survival to discharge. And again, this is survival to discharge. Were they vegetative? Were they functional? We don't know. But at least they did achieve 16% survival to discharge. Look at UAE, 3 to 5%. And why do I say 3 to 5%? Because the data that's out there are scattered. So we don't have a national registry that would give us confirmed data. Look at the rest of the GCC. Kuwait, 1%. Saudi, about 5%. As well, sort of some personal effort to collect data from one center, and it's out there. But something to tell us about at least that center may reflect Saudi, may not, but at least best estimate would be 5%. Qatar, 8%. Oman, 8%. And USA, 10%. So if we want to identify Denmark as actually a good outcome, then we have a kind of a lot of work to do to reach that 16%. Now, if we go to the second facet, and actually most of my focus will be here. So the pre-arrest kind of facet. So if you go to the pre-arrest part, honestly, I personally think if we catch patient early, if we recognize them, we catch them early, perhaps we can help them better than when they come in arrest or about to arrest, right? So if you wonder about this literature, there is not much out there. So who does arrest in the emergency department? We've done a recent work I'm going to share with you in a second. And before that work was done, being in a trauma center, I did believe most of my arrests in the ED are trauma arrests. But then when we looked at the data, it did prove me wrong. And in a second, I'll show you that data. So who does arrest in the ED? What's the etiology? Is it MI? Is it sepsis? Is it trauma? Can we predict arrest before it happens so that we can actually act faster and prevent it? What are the predictors of survivor? So those who arrest in the emergency department, what can we do for them to improve their survival outcome? And is the survival of ED arrest better than patient who arrest in the hospital or in the ICU, for example, or out of hospital cardiac arrest? So literature, again, very scarce. However, few sort of like kind of papers were out there. So in 2008, a retrospective 60,000 patients about ED cardiac arrest, and they compared them to ICU telemetry cardiac arrest and patient on the regular ward. Simply, ED cardiac arrest did better regarding neuro outcome and as well had shorter length of stay, which is, if anything, something that would please us as emergency medicine physician, right? Now, when they explored why, apparently patients who come to ED sick are younger. I mean, it makes sense. If they have comorbidity, they'll be admitted with multiple comorbidity, then eventually they might arrest in the hospital or in the ICU, right? So it makes sense, patients who come acutely ill to ED might be younger. And then they come early in the illness, so you catch them when their end organ damage is reversible. So if you do a good job, then actually you help them from kind of getting irreversible end organ damage. And then they have less comorbidity. Perhaps, again, it's the young people who would deny or will not go and check their blood pressure, their diabetes, and whatever. And then when they come to you acutely ill, you still have a room where you can sort of help them. Now, this is data from a year and a half that we collected where I work at Mafraq Hospital. So we looked at all ED cardiac arrest that came to us 2018 to 2019. So a year and a half, 18 months. And then we had 209 cardiac arrests. We excluded anyone who came as out-hospital cardiac arrest or who arrived with recurrent, they called recurrent cardiac arrest. So someone arrested out hospital, they got ROSC, they came to ED, not an arrest, they arrested again. So these were excluded. So we purely looked at patients who came in alive, arrested in our ED. Out of 2009, we had 20 patients. Now, the median age was 60, so that kind of give you the age range where people could arrest, for example. I was very concerned myself, like I was very kind of caring. I wanted to know how they present to us, what's the chief complaint? Because that would help my triage nurse to pick them up early, right? So in this 20 patient, about 40% had altered mental status, drowsiness. This was assuring, because usually altered mental status will not end up being in your waiting room. Then 20% had shortness of breath, and only 10% had chest pain. We are a 24/7 BCI center as well, so that was surprising. Again, I thought trauma would be the major sort of killers, but apparently it was not. Initial rhythm, which was different from the literature published, most literature published, initial rhythm was VFib or majority was VFib. In our 20 patient, one only was VFib, but mostly kind of 60% or 70% were BEA. Now, survival to discharge was 40%. So remember the out-hospital cardiac arrest in UAE, 3%? Now, ED arrest was 40% in our sample, it's a small sample, but that does give you an impression that if we do a larger sample across multiple centers, we might learn something we did not know. So average length of stay before cardiac arrest, survival 31 minutes. People who did not survive stayed with us for 66 minutes, which could be a good news or a bad news. The way I would think about it, either we did not recognize them, so they were in ED for long enough before the arrest, which would be a bad thing, right? Or we did recognize them, we were actively resuscitating, and despite resuscitating effort, they arrested. Hence, their outcome was bad and they did not survive. So we're still digging down deep on the data, so I don't have answer to that. Now, we did use Cox regression, we did use as well a computer algorithm to try and identify what could predict the survival outcome in this patient population. Now, the list in the bottom, the non-predictors, age, gender, vital sign, Muse and Muse 2 did not predict survivor. These are important because these, if used before the patient arrest, could predict actually arrest, but would not predict survivor. But the predictor of survival was CPR less than 5 minutes, plus heart rate more than 110. And in a way, this is so far as assuring. I mean, we're still in the data, like a data analysis phase. But this was assuring because for me, if someone has heart rate more than 110, then maybe I am in the early resuscitation phase, they arrested, I bring them back, right? So that would predict survival. And when we looked at it, we looked at survival to discharge. We did not look at sort of like all their status post-discharge. Now, if we come to the arrest phase, so remember we had four phases. So arrest phase, and keep me with time because I'm concerned I'm gonna go over the 15 minutes. So the ED department, so if you wanna look at the ED arrest, what would make a difference? If you arrest in this room, perhaps you are safe. You have all these emergency physician and emergency medicine practitioner around you, you'll be safe, no question, right? I will manage to get you to hospital on time. So arresting in an emergency department would make a difference, and in a second I'll tell you why. Look up this literature. Simply, it's a study done across about 10 years, looking at if an emergency department closes near you, how would mortality be? And if a new emergency department opens near you. And the distance chosen here was 30 minutes. So if the next emergency department, like if the emergency department near you is farther than 30 minutes, then you should be concerned because simply your mortality would be increased by 2%. If you have an emergency department within 30-minute radius of your living area, then your mortality or your survival rate is increased by 3%. So I would say next time you decide about where you're gonna live, just check where's the nearest emergency department, make sure it's within 30-minute radius. Now, what we did over past 5 years in Abu Dhabi, we defined what emergency department is. And I wanna this is online as well, you could capture the reference there and look it up. I mean, the major, we had defined standard for emergency department. The major part that we had struggled a lot to define, and we defined it as minimum standard, you need to have one trained emergency physician in that department 24/7. And again, this is minimum standard. Some hospital could choose all physicians would work in the ED would be trained. However, in Middle East, we don't have enough trained emergency physician. That would be unmeetable. Then you'll end up with no emergency department. But at least if you have one trained who would run the resus, who would manage the sickest patient, then you are kind of improving a sort of standards. And then as we train more people in the future, perhaps that should change, and only trained emergency physicians should be allowed to work in the emergency department. Department who did not have trained emergency physician were actually licensed as urgent care center, not as emergency department. And that makes a big difference. And in a room like this, in an emergency medicine conference, I'm sure we're all gonna agree. When we sit in a multidisciplinary room, then we have disagreement on that. So the other thing that makes a difference in ED arrest is high quality CPR, so that's no brainer, that's kind of done and known, well known. And I added there automated CPR, where we know high quality CPR, automated CPR have no difference. But then when you don't have much resources, you'd rather save that hand that would do CPR and just put the machine on, or if you have to run a CPR for a long time. So patient going to cath lab, for example, with CPR ongoing, or hypothermic patient, or a child who you're gonna go longer, then you would rather have that automated CPR there. Now, eCPR coming in you to the field, if you have a 24/7 eCPR service, you could save 12 to 15 lives per year. So data still there, cost effectiveness, which I'm kind of concerned about. If you're gonna go to expensive intervention like this, by all means go for it. But I would say focus in the low sort of cost intervention before you sort of jump to eCPR itself. Now, post-arrest care is what perhaps most of us think we are doing, but then when you ask your colleagues around, perhaps we are doing it batchy. So this is something I'm working with my team to establish, bring to our kind of department. It's a Royal College of Emergency Physician UK checklist for post-arrest care. And checklist simply because I might do part of it, forget other part selectively for some patient. My colleague may simply get busy with another patient and ignore this kind of phase, thinking I called ICU, they'll take him up. But then post-arrest care kind of goes sort of beyond, goes delayed, where you lose the effectiveness of it. So all your resuscitation effort, pre-arrest, arrest in ED, get wasted if you don't care after the patient post-arrest. Now, effectiveness of resuscitation outcome measure. And because time is up, so 2 minutes more, so this is something that I'll leave for you as well to explore. But if you want to think about, US is going since 2007 in outcome-based healthcare, right? So instead of me, I saw a patient, you pay me, let's say $500, then simply it's based on that patient outcome, you decide how you're going to pay me as a physician, as a hospital, as a department. So this is how they do their payment for hospitals. Mortality takes 22% weight on the star rating of the hospital, and that determines the payment after that. Safety of care, 22%. Readmission, 22%. Patient experience, 22%. Look at the access KPI. So, for example, efficient use of imaging, timely of care, so like door-to-doctor time, door-to-door time, all these KPI we sort of follow, they don't have that much weight anymore. So if you translate these sort of outcome to ED, mortality, then you want to look at your cardiac arrest in ED itself and explore the findings and explore the outcome. Safety of care, admission rate. How many patients do you admit? When they talk about safety of care, if I admit you to the hospital when you don't need admission, then simply I gave you hospital-acquired infection when you should not have gotten that infection. That's not a safe care. So that's why monitoring admission rate per hospital is important as an outcome. And then readmission to emergency department within 72 hours for same chief complaint. How do you know patient you send home was an appropriate discharge decision? You will not know till you track your return within 24, 48 hours or 72 hours. You choose your time target, but I would be biased to say 72 hours because then if they relapse for same chief complaint within 3 days and you have unplanned return, then that kind of would mean there's a problem there. Now for cardiac arrest itself, there is the COSCA, which is the core outcome set for cardiac arrest. And in brief, you don't want survival to discharge. What you want is 30-day survival, neurological outcome, plus 90-day quality of life. If you give me that, that's an outcome I care about. If you only tell me they survive to discharge, but then they are vegetative state, well, that's more burden in the community and more burden in the patient and family. But if you give me this as a measure for cardiac arrest, then I know how effective your resuscitation is. Now, take-home message, and that would kind of conclude what I said. We need to improve our ED resuscitation, looking at the whole process. And it would be simply starting with the National Registry to capture all cardiac arrest and analyze the factors. Otherwise, we'll be reporting scattered data from different hospitals. And then resuscitation outcome, we need to report in our literature and as well as organization, a significant outcome that will make difference for a patient and community rather than outcome that would just make the number looks better. And then ED outcome measure, mortality, safety of care, readmission. So start looking at your department certain reattendance rate. That would be the minimum to start with. Mortality, perhaps we're all kind of addressing, but then maybe you need to analyze your mortality in further detail. And I'll close with that, and thank you, and apologies for taking a bit longer time.